So I'm supposed to finish up here by talking about lessons learned. And a lot of the themes I'm going to talk about are going to, I think, echo some of the earlier comments from the other speakers. But I don't really think I have lessons to offer you as much as mistakes I've made. Sometimes that translates into learnings and sometimes it doesn't. And some of these are really more just kind of general anxieties that we've struggled with as we've tried to evaluate one particular policy intervention in Ontario. I should also mention, you see that long list of authors at the bottom of the slide. There are a lot of people involved in this project, and I won't name them all, but you can see them there. So there's my conflict of interest as well. No, I have no financial conflicts of interests, unfortunately. I have previously served as an advisor to the Ministry of Health on this strategy and helped in part to design it. So I suppose that could be considered a conflict. So I'm going to talk about an emergency department intervention that was trying to reduce ER wait times and reduce overcrowding in Ontario. But this is a problem that is common across Canada. It's also common in many other developed health systems as well. It's a problem that's associated with adverse clinical outcomes and with patient dissatisfaction. We know it's a major driver of satisfaction. It's also a politically charged issue. This is an issue that has claimed hospital administrators, health service system administrators, ministers of health, and so on. And it's something that regularly hits the headlines in many jurisdictions across the country. So in 2008, and I won't go into the history of why this was launched in 2008, I'll just say it was, the Ontario Ministry launched what they call their ERALC wait time strategy. ER, you know what that means, emergency room. ALC is alternate level of care, and that was because of the feeling that part of the problem was inpatients in hospitals who don't need acute care anymore but are waiting for long-term care, or in Ontario those are called ALC patients. I won't go through this slide. This is just to show you that the strategy had sort of three major prongs. One was around trying to identify alternatives to emergency department utilization. The second was to improve patient flow and capacity in emergency departments. And the third was to improve patient flow and speed the discharge process for inpatients. What I'm going to talk about today is what's in that little box there called the ED Process Improvement Program. And this was a lean type intervention that was implemented in 4 waves. Each wave constituted different numbers of hospitals over about 4 years, and the aim was to implement it in around 80 to 90 hospitals overall. But what I want you to take away from this slide is the fact that this intervention was just one of many that was occurring simultaneously. And so our challenge was what the ministry wanted us to answer was, what did this particular intervention do? Did it work or did it not work? And to tease that apart in this kind of mass of other things happening simultaneously in the system is very difficult. And of course, sites that got this intervention may or may not have gotten many of the other ones, and control sites that didn't get this intervention may have gotten others, etc. So it was a very complicated picture. What was the EDPIP? Well, it was an 8-month structured program designed to support improvements in reducing ED average length of stay or wait time metrics. They used the Toyota lean approach. The idea was to address flow from end to end, meaning in the emergency department, on the inpatient units when patients were being admitted, primarily general medicine patients, and at the time of discharge as patients were being sent home. They brought in coaches, they had toolkits, and so on, but it was not overly prescriptive. In other words, hospitals could design their own processes and choose what to target and what to focus on. That wasn't decided for them. In terms of our evaluation, we had multiple levels of evaluation. And just before I talk about that, I should say that another lesson, I guess, or an anxiety that we had was when we first got funded to do this by the ministry, we pitched a randomized controlled trial. We said, let's randomize hospitals. You can have, all the hospitals will eventually get it. We'll just randomize the order in which they'll get it. And we'll be able then to have sort of a step wedge approach to the intervention. And the ministry said, that's great. We love that idea. Here's your money. But then the individuals occupying those offices changed, time went on, and the ministry changed its mind. And we struggled very much with this. We felt, no, we have to stick with the randomized trial. Here's why, all these convincing arguments. And yet in the end, it became an observational trial by virtue of the ministry's decision. So I guess one lesson is you got to be flexible. If you're going to work with decision makers and evaluate complex health interventions, you can't have a pristine view of what methodology you're going to use, you need to be flexible, especially in this example where we did not control the intervention. We were being brought in as sort of third-party evaluators, which is a little bit different from some of my predecessors. So we had a quantitative evaluation, which was based on administrative data. The primary outcomes were the length of stay metrics that were being targeted, but we also looked at a variety of other outcomes or unintended consequences. They could be adverse or they might be unintended benefits, but we looked at a range of unintended consequences you can see there. We also carried out qualitative interviews in 10 sites and surveyed staff at the end of the intervention. We also carried out a survey at the beginning of the intervention to understand the baseline hospital culture and organizational characteristics. And finally, we're in the process now of finishing a chart review at about 25 sites across the province to assess whether quality of care was otherwise impacted by sites that actually managed to reduce their ER wait times. But today I'm just going to focus on what's in the top box, the quantitative evaluation. So, thinking again about in retrospect, you know, some journals now say after you publish your article, they want a little box. In retrospect, what would you do different? Well, this was obviously a multi-method evaluation. We were happy about that. But it was very much an after-the-fact evaluation. We were going in after the intervention was done, doing interviews, gathering our data. Admin data is often delays of a year or more by the time you get the data. So one question that we have is, could we have done more to help with improving the intervention as it was happening, as opposed to coming back with answers later on to say whether it worked or didn't work? We carried out an evaluation so far of 2 waves. The first wave, wave 1, which was 5 sites. We had 43 control hospitals identified for that wave. We had the second wave was 16 intervention sites, and there were 18 controls for that. We used generalized estimating equation models, controlled for important covariates, the usual sort of admin data approach to these sorts of observational studies. And we looked at outcomes 6 months after the end of EDPIP to try to gauge sustainability. And I guess the obvious question is 6 months long enough? Is it long enough for the intervention to have worked, as Sanjeev mentioned? Maybe it takes a year after the intervention's finished for you to really start to see benefits. Perhaps also maybe the intervention has run its course, so the benefits have run its course long before this. But this is what we chose, and of course the question is, was this the right timing? These are just the univariate or the basic before-after results. This is just for wave 2. And I'm showing you each bar here is a separate hospital. And what you're seeing is the change in the median length of stay before and after the intervention, at 6 months post the intervention. And what you see is that for a lot of the hospitals, about 10 of them anyway, 10 of the 16, there were reasonable improvements in length of stay. Some quite substantial, some more modest. A couple of hospitals, nothing much happened, and one at least got substantially worse. And you might say, well, this is just sort of there's heterogeneity, there's randomness, random differences in here, and so let's cut to the chase and come up with a summary measure of what the benefit was. Well, this is what this is. This is now our adjusted results, where we were looking at a single summary measure for our main outcomes and the unintended consequences that we looked at. And again, I won't belabor this, but just to draw your eyes down the center bar, which is at 0, and if the confidence intervals cross that vertical line, there's no effect. And the bottom line is, overall, there really was very little effect of this intervention when you're talking about the average effect. So very modest improvements in median ED length of stay, but clinically probably unimportant, and some very modest benefits also in terms of reductions in leaving without being seen rates and 72-hour revisit rates. So you sort of look at this and say, ho-hum, not very interesting, didn't work very well. And basically what this tells you is that, in fact, the EDPIP sites, the sites that got the intervention, actually did improve, but the control sites improved just as much, and in some cases improved even more. And I think this highlights, again, a lesson that highlights the importance of controls in complex interventions and the limitations of before-after designs. If we'd only looked at before-after, we would have thought there were substantial improvements. By bringing controls, we see that, in fact, the control sites were improving just as much in many cases, probably because they were being exposed to that whole mass of interventions that I showed at the beginning. But let's go back to this slide for a moment. And when we look at this more closely, we sort of wonder now, maybe there is something here going on. Maybe this is random differences, and some hospitals got better for whatever reason, some others didn't. Or maybe there is real signal in this heterogeneity. That this wide variation is not something we want to suppress, which is what we normally do with statistical analysis, but it's something we want to really explore. Maybe heterogeneity is not noise. There's a wonderful article that was titled Heterogeneous, Not Noise and Jam a few years ago, and I encourage you to read it. And is this about the importance of the hospital context in which these interventions were implemented? Here is another interesting way of looking at this data. What we did, I mentioned at the outset that we did surveys of hospital staff at the end of the intervention. And we asked them a bunch of stuff. But one of the things we asked them is, do you think that the intervention was a success or a failure? We had a 5-point scale. And what we've done here is we've drawn 4 quadrants. With, on the x-axis, you're seeing the objective measure of improvement, which is the actual length of stay. Did it get better? Did it get worse? On the y-axis, you see the subjective measure of the staff saying, we think it was a success or we think it was a failure. And the two, the top left and bottom right quadrants, are the ones where let's say top left to begin with, the perceived success was high, the staff thought it was a success, and in fact, if you look at their numbers, they got better. The bottom right is the quadrant where staff thought it was a failure, and the numbers would back them up. Their length of stay did not improve or got worse. But what we think is really interesting are the 2 other quadrants, the discordant quadrants. Look at the one at the top right, where staff think this is a terrific success, and yet they didn't get any better. Or the bottom left, where staff think they were a total failure, and yet their numbers got better. So what's going on here? Why is it that there's staff in some of the loser sites, so to speak, who feel like winners? And there's some staff in the winner sites, so to speak, who feel like losers. Is context key to understanding this discordance? And this is something that we're now exploring in some additional analyses. So what would I say are some of the key lessons that I've gleaned from this experience? Well, number one, and this has been mentioned before, and I'm certainly no expert in this, but we, I think, missed an opportunity to use the evaluation as a tool to improve the intervention. And this is something now, as we're working on other interventions, that we're trying to not repeat again. The use of controls. I mean, we love controls in health services research. They're obviously necessary, but they're not sufficient. You can't assume that you've identified controls. First of all, there's all sorts of issues about residual confounding and apples and oranges and so on when it's not a randomized trial. But nonetheless, I think even in a randomized trial, using controls is necessary, but it's not sufficient. You need to go beyond that in terms of understanding what you're seeing. Are we measuring the right outcomes? The ones we looked at were the ones prescribed by the ministry, but were they the right outcomes from a patient's point of view? I'm not sure about that. Are we patient enough to allow time for an intervention to work? We've already talked about that a few times. And the last thing I'll measure is this whole issue of heterogeneity. And I want to sort of paraphrase. This is kind of a clumsy paraphrasing of Marshall McLuhan, but maybe the context is the intervention. Maybe when we think we're bringing in our intervention, all we're really doing is somehow catalyzing the existing resources that exist in that hospital, personnel, operational, whatever you want to make it. But maybe the context is really the intervention, and you're just kind of reorganizing it in some way by virtue of this intervention you're bringing in. And I think that that's something that really is worth exploring in much greater detail, as opposed to trying to control it out of our analyses. We should probably be trying to draw it in. I'll stop there. Thank you very much.